Good afternoon to all of you that have convened here and to all of you that are following us live. My name is Tony Punturieri. I'm a program officer in the Division of Lung Diseases at NHLBI/NIH. My fellow panelists here are down there, Dr. Byron Thomashow from the COPD Foundation, the chairman of the board, and Henry Moehring, president and CEO of the Alpha One Foundation. We are gathered here to deliver something that the COPD patients have waited for many, many years. We are here officially to launch the first national COPD action plan. This originated not only from the needs of the community, but also from a request from Congress a few years ago that asked us, NIH and CDC, to produce a comprehensive plan that could put the community at ease in terms of tackling this horrible disease, creating a pathway that everybody could follow, from patients to caregivers, to healthcare providers, to industry, to patient advocacy organizations, and of course to researchers. As you can see, the plan consists in 5 major goals, and around these major goals, specific points are articulated. The 5 points deal, the first one, with the patients, because again, the plan is all centered around the patients, and it wants to empower people with COPD, their families and caregivers, to recognize and reduce the burden of COPD. The second goal is directed at those instead that are healthcare providers in the health provider sector. And it calls to improve the diagnosis, prevention, treatment, and management of COPD by improving the quality of care delivered across the healthcare continuum. The third one is about data collection. Without data, of course, we don't know where COPD is, who is affected. The fourth one is the one that calls for research. More research is needed, of course, to better understand the disease, to prevent it, to understand its causes, to ameliorate the treatments and the management of COPD. And finally, the fifth one articulates the desire to produce checks and balances for this plan and use the product of the previous 4 goals to deliver recommendation into research and public health care actions. COPD is a horrible disease. In 2015, it killed more than 150,000 of the US population. It also is not only the 3rd leading cause of death, but the 4th cause of disability in this country. And since 2008, more women die of COPD than men. I would like now to give the microphone to Dr. Byron Thomashow, which will express his remarks about the plan. Thank you, Byron.
Thank you, Tony. So for those of us who have lived in this community for a long time, this is a very important day, I think. 16 million Americans diagnosed with this disease. Millions more have the disease but have not yet been diagnosed. The 3rd leading cause of death, the changing face of the disease. More never smokers, more women, more younger people, more working people. Tremendous costs, physical, emotional, financial. $50 billion a year in medical costs, and that doesn't even begin to approach the loss of productivity in the workplace, issues of absenteeism and presenteeism. But despite those staggering statistics, it's worth repeatedly stressing that COPD, even today, is almost always preventable, that COPD is almost always treatable with what we have now. We face a number of challenges. We need to do a much better job with prevention. We need to find more of those millions suffering from this disease and yet not diagnosed. We need to make sure that those who have already been diagnosed have been appropriately diagnosed. We need to make sure that those who have been appropriately diagnosed are being appropriately treated. We have medicines now that can help. We have pulmonary rehab, an unbelievably successful technique which is rarely available. That needs to change. And perhaps as important as any of this, we need to move away from believing that COPD is all the same, because it's not all the same. And we need to move away from treating COPD as it's all the same. And in that regard, NIH deserves a tremendous amount of credit for several of the major programs, COPD Gene and Spiromics, which are helping us to define subsets of this disease that will ultimately lead us to more personalized medicine, more precision medicine, better treatments, individualized treatments, ultimately to cures. This program, the National Action Plan, will help us begin to get to these steps. NHLBI deserves an unbelievable amount of credit for getting us to this point, working with the CDC and the other government agencies. But now the burden falls on all of us. We need to move this forward. Otherwise, this will not work. So in that regard, I just want to touch upon a couple of things, because the COPD Foundation has a number of programs which actually impact or can impact a number of these bullet points. So I'm only going to touch on 3 of them, but it can sort of set the stage for what we can do working together to make this work. So several years ago, the FDA actually approached the COPD Foundation regarding the issue of biomarkers. So as most of you guys know, biomarkers can be a blood test or an X-ray test or an exercise test, a quality of life measure. There are many different types of biomarkers. Why are biomarkers important? They're important because they're the endpoints of clinical trials. And until recently, the FDA only had approved 3 biomarkers for COPD, for a disease of potentially 30 million people. Out of that conversation came the development of the Foundation's Biomarkers Qualification Consortium, really a remarkable partnership between investigators and industry working with government agencies, sharing proprietary data. I never believed that would happen, and allowing us to move forward, allowing the COPD Foundation to submit these to the FDA, and we now have 2 more new biomarkers because of that, approved biomarkers. Fibrinogen and the SGRQ, a quality of life measure, and there's a lot more that we need to do moving forward. More biomarkers are going to mean more clinical trials, so we can move this whole process forward. In that regard, the second is the COPD 360 research. So we have established, initially with some help from Punturieri, a COPD research registry filled with thousands of patients with COPD. The goal is to have thousands and thousands of people with different types of COPD. People who've agreed to join clinical trials, because for us to move this forward, this needs to be a partnership not just with industry and investigators, but with the people who have the disease and their families. We need their help. We need your help in order to move this forward. Otherwise, we can't possibly get to where we need to be. If we have people with different types of the disease, we can move forward with trials that will lead us to treatments that we need. And finally, is something called COPD 360 Social. Now, being old, I must say, I'm not on Facebook, and I really wasn't sure what to make of this, and I was wrong. COPD 360 Social is sort of like Facebook for the lung. When we started it just 2 years ago, there was no one. Now we have over 30,000 members, and we're getting over 250,000 unique hits a month. 250,000 unique people with this disease. The COPD Foundation will use these programs and whatever else we have to work together with any and everyone to move this process forward. A couple of last thoughts. As most of you know, John Walsh founded the COPD Foundation. John Walsh founded Alpha One, and Henry's going to talk about that in a little bit. John would be unbelievably excited about today. What he would say is, this finally will allow us to bring COPD out of the shadows and into the light. And the COPD National Action Plan will allow us to do that, and I do miss John. Thank you.
Good afternoon, everyone. Byron, that's a tough place to start. I miss John as well, and you know, that voice of energy and passion, I think, is a voice that we need right now. And there are a number of us that have voices, and I encourage us to lift them up in that tone. As Tony said, my name's Henry Moehring, and I'm privileged to serve as the president and CEO of the Alpha One Foundation, and one of the hats I'm wearing standing here is that. The other hat is I'm an alpha-1 antitrypsin deficiency patient and also a COPD patient. And that's the voice that I want you to hear today. The Alpha-1 Foundation is grateful to the National Heart, Lung, and Blood Institute and all of the stakeholders that have come together to draft this plan, and we appreciate being involved in it from the beginning. I was one of the people that was at the town hall and have been in discussions and focus groups and meetings up to this point. So today's an exciting day. The plan truly reflects the voice of our community, and at the press conference earlier today there was discussion about that patient voice, and that patient voice is embedded in this plan, and that patient voice is one of the successes, one of the elements of success that we're going to need moving forward. You've heard about the burden of COPD. Too many people are going undiagnosed or underdiagnosed or misdiagnosed, and they're not achieving their best quality of life. There are options. There are options for treatments. In the Alpha-1 space, there is no cure, but there are opportunities for education and support and treatment. And Alpha-1 is the largest known genetic cause of COPD. So the Alpha-1 Foundation has a vested interest in being here today to make sure that we identify the people in the COPD community that are there because of the impact of Alpha-1, to make sure that they're properly diagnosed and on, as Byron talked about, the number of paths, on the right path for the Alpha-1 community. We strongly support this national action plan. We look forward to the opportunities that it brings in opening doors, and we are committed to being at that door as a member of the coalition that's going to move this forward. Earlier today in the press conference, Dr. Kiley made a reference to football. And football is a big thing at my house, and I will follow on that analogy in saying that the Alpha-1 community is suited up and ready to play offense. And the COPD action plan is an amazing game plan that we have to go in with. So Dr. Kiley, I hope that I'm using your reference well. We are in the game. We are ready to play to win, and I think the COPD action plan will get us there. The 5 goals of increasing public awareness, educating providers and patients, better understanding of COPD through data analysis and research, and really bringing all of the stakeholders together in a collaborative way to guide this process moving forward, I think are really critical. And there are elements of Alpha-1 in each one of those, and as a community, we stand ready to be an active role and an active part of that. Today is certainly a milestone as this plan is unveiled, both for the plan and also for the collaboration across the entire community that went into writing it. We have a comprehensive national action plan. Again, as a patient and a stakeholder in this plan, I would challenge that this is not an end point. This is not the piece that we wanted to get to and check off the box and move on. This is the starting point. I think it's interesting that we tie action and plan together in the title. We must use this plan to drive change. We have to implement these actions into the work that we do in the community every day. Each of us as an individual or an organization has a role to play moving forward, and we must find innovative and sustainable ways to get the job done. The plan gives us great direction, but we as the stakeholders of that plan have to make it happen. The Alpha-1 Foundation is committed to achieving the goals of the National Action Plan, and as I said earlier, we're suited up and ready to play. The millions of Americans are counting on us, and you've heard about that burden of COPD over and over. Now is the time for us to get busy. Now is the time for us to take the plan and put it into action. Thank you.
Thank you. We are now open for questions from the public. Yes, Sandy. Wait.
What's the first thing we have to do? Where do we start? The plan's out there. Where do we go?
I'll take this one, and then my colleagues can probably expand on that. Clearly, as Henry said, this is a blueprint, and it gives us a track to follow, but it's not going to work on its own. We need the help of everybody in the community, from patients, organizations, to industry, to, of course, the federal government, to try to bring this to fruition. A provision on the fifth goal is actually to create a sort of Uber committee, if you want, if you allow me the term, that would follow the progress of the plan. Because the plan is a piece of paper right now, and as such, could as well end up on a shelf and get dusty. But we don't want to do that. We need to be nimble. We need to be ready to pounce on any chance that we have to implement part of it or discard part of it if eventually they will not become useful to the patients. And so it's this today, again, as everybody said, it's a starting point. We needed to start from here, but it's just the beginning. Now the rubber has hit the road. Now we need to move forward. You want to add more?
No, I mean, I think that what Tony said is true. This one? Turn this on?
No.
Doesn't matter. Just use this. Okay. So I think what Tony said is absolutely correct. I mean, the burden is on us to get our groups together to work on these things so that we can move this process forward. We really need to mobilize the community, to be perfectly honest with you. There's only so much that investigators, government agencies can do. The community needs to find a voice. They need to help us. I mean, Valerie's here from Hawaii, and Valerie's an angel, and she does tremendous things. But if I could have cloned John, if I could clone Valerie, if I could clone Grace Ann, we need more people willing to step up, because ultimately this is their lives and their future. We will try to get that point across in social, and we do have the ability to reach out to an awful lot of people. But this will only be successful if the community is motivated to make it so. That's what I believe.
I think Byron talked about some of the resources that the COPD Foundation has. I would echo that with some of the resources that the Alpha One Foundation brings to the table through our clinical resource network of physicians and centers across the country, and through our patient network. I think those are two places that we can go very quickly to get this tool in their hands. We've talked a lot about patients and patient empowerment, and I think one of the first things, and it's alive and well in our community, is how do we give patients the resources they need to be successful in sharing their stories and in getting the point across. I think the plan's a great tool. We resource patients. Karen Erickson, sitting here in the front row, really does a great job with the Alpha One Foundation in engaging and involving patients. So I think those would be the day one starting points that I would encourage. And then it really is building those collaborations. Who are the stakeholders that need to be engaged and involved, and how do we get them to the table?
Let me just touch upon Henry's point, because I think the alpha population is really a remarkable subset of COPD. We've done a lot of work in COPD gene, again, thanks to NIH. We're not going to find another single thing like alpha. We're going to find combination of genes that we can work with, but there will not, I don't believe, be another one quite like alpha. But they have a unique community, a community that, thanks to a large extent to the work that you've done, Karen, that Sandy's done and others have done, is already motivated and involved. We need to, and that's not the only one. There are other diseases that have far smaller, less impact. They need to be dealt with, but far less impact than COPD does. The LAM Association, for example, cystic fibrosis. They've done remarkable jobs motivating their community to step forward. We have not been able to do that yet. And the community needs to understand that this can't be done by people like me or Henry or Tony. We can't do that unless the community is willing to stand up and say, we want a better life. We deserve the ability to breathe. Well, you got to work for that, because otherwise it isn't going to happen. We can't do it without them. And it has been done in other groups, and Alpha is an example of that.
An additional point, Sandy, is that within the plan, there is the present and there is the future. The present is what we have achieved. Of course, through research in the past 15, 20 years, we made enormous progress. But is everybody treated at the level of progress that we have achieved? No. Do doctors know how they or other healthcare providers how to best treat their patients? we have the concept that each patient is unique, right? Personalized medicine. Have we translated the knowledge that we have reached so far into a practical application for each patient? Obviously not. So that is the present, the low-hanging fruit, if you want, that we can work on. But on the other side, I think I said it at the beginning, that this is an incurable disease. And being an incurable disease, it means we need to find a cure, or a way at least to stop it. And that's the future. Of course, we are working, but more research needs to be done in that direction.
I think it's important, I don't mean to be negative about this. I'm not. I'm very excited about what we can do here. I think it's, Barbara Yuan wrote a paper a year or two ago which compared 2007 to 2014. And while there has not been nearly enough progress, still less than 50% of primary care physicians are treating COPD patients according to guidelines. But there was positive news with that. In that 7-year period of time, a dramatically higher percentage of providers believed that this was a treatable disease, believed that we had treatments that could make quality of lives better, that we could make exacerbations less frequently. We have made progress because of everything that we're doing. We need to build on that progress, and that's what this plan does.
Along those lines, I'd like to say that in 2000, when I was diagnosed, my Department of Health in Hawaii had never heard of COPD. Now they all know what it is. But they always say that one of their limitations is categorical funding. And I'm wondering, what can we do to help make there be categorical funding so that there's some institutional support for COPD, because that's the only thing our Department of Health will fund?
That is not a question that is good for me, but I can give you an answer. That is, it's up to the community. Right. It's up to the patients, and they can elaborate on that. What I can tell you is that, categorical funding may be good, but it's not necessarily the only thing that moves forward knowledge and science. I'll bring you a silly example. Think about a new antibiotic that could come out and prevent an exacerbation, as Byron, or cure an exacerbation. And guess what? There are people that are studying frogs, the skin from frogs, and they find antibiotic out of there. So you see research that is funding a reptile research can then be beneficial to a human, and in this case to a COPD patient. NIH is full of this kind of examples. And
so the only thing I would say to that, Valerie, is that Barcelli talks about having the slowest walk in the world to Capitol Hill, with people pulling their oxygen tanks behind them. The patients, the people, the families who have this, and everybody knows somebody with this. Everybody knows somebody at it. They have to step up. I mean, Grace Ann has done some remarkable things with rehab centers in rural America. I mean, it wasn't touched upon, but the data from the BFRS, which is the largest healthcare survey done in this country, clearly shows that this is a healthcare disparity issue. If you if you make less than $25,000 a year, you're dramatically more likely to have that. That's not right. If you go to places like Grace Ann and Ted have set up rehab centers, there's nothing there. What they're providing is remarkable. People should stand up and say, we want rehab. Rehab is cheap. It's not transplant. Rehab is really cheap, and it really works. It's ridiculous that in New York City we basically have 3 rehab centers. That's silly, right? We need to correct our priorities, but we need the force of those 30 million people in order for us to do that. I'm sorry, I don't mean to spread the burden. We'll do our part, but we can't do it without a lot more people like you.
Yeah, and I think as a patient, I would encourage every patient to develop that relationship with their legislator. We live in a representative democracy. We have a roadmap for governance. And we need to be active Americans to make sure that our voice is heard, not just once, not just in an email, not just, the Capitol Hill visit is absolutely essential, but that can't be the only thing. It has to be that consistent presence. And Valerie, I know part of your success has come from that day in, day out, consistent messaging. And my representatives still answer the phone, which is a good thing, but I'm going to continue to make those calls.
Even if you call, Henry?
Even when I call. But I think we have to mobilize that element of our community.
I just want to say what I said before. I don't want people to come out of this with a negative feeling. It shouldn't be. This is a really exciting day.
Absolutely.
John would be jumping up and down with excitement over this. We're not where we need to be, but this was a step we needed to take, and NHLBI was really fantastic to get us to this point. And now together we need to figure out a way to get it beyond this.
Since we have another question here, but since Valerie spoke, there's something that I wanted to mention that is important. Valerie is a non-smoker COPDer. We know that 25% of people with COPD have never smoked in first person. They could have been maybe secondhand smokers, or they could have inhaled something else, or they could have been an alpha-1 antitrypsin patients, or others. There is a lot of stuff out there that we don't know about, and there is new stuff that comes up. And there is new and emerging threats every time. You think about a disease as something that is in a box and never changes, but diseases changes all the time. And the analogy is, yes, you have a new virus, a Zika that comes out, but proportionally the same thing happens also for chronic lung diseases, for example. We had a question in the front.
Yes, Matt Maloney from Respiratory Health Association in Chicago. We can play a role, our organization, in the COPD community that we're engaged with, but who's going to coordinate, what entity is going to coordinate the implementation of this plan and make sure it's moving forward?
Obviously, the next move for the plan, I mentioned it, that in Goal 5 there is a proviso to create a coordinating body. And how that is going to happen is going to be the discussions amongst all of us, amongst the community of the next months to come. We probably are going to have a meeting and we're going to exchange ideas and ways to how to deliver this, because clearly we need a governing body to do checks and balances on the deliverables. Thanks for that question. The front. Mike?
You may just have to jump up and down and scream. What happened?
Now I'm embarrassed.
Speak into Tony's
Now I'm
tie.
embarrassed. I'm associate editor of Chest Physician, and it's a news publication primarily for pulmonologists. And I just wanted to know, what can my readers, pulmonologists and other doctors treating patients with COPD do to immediately help the NHLBI and other partners begin to achieve the goals of the COPD action plan?
Clearly, I think this is a better question for Byron, since he lives this and breathes this every day.
Okay, so
He is a pulmonary doctor.
So what I would tell you, to be perfectly honest with you, is that it shouldn't be the pulmonologists. It should be the primary care doctors. This disease lives in primary care. That's why we haven't found the 12 to 15 million who have it and are undiagnosed. We need to figure better ways to get the word across. And this is not as meant as a criticism. I still do a lot of primary care medicine. I'm an internist. I'm not just a pulmonologist. But there is so much limited time, and there are so many disease states to deal with. I think it came across this morning, and maybe I'm misconstrued, but this is a disease which is filled with comorbidities. And it's not happenstance, and it's not purely related to the cigarette smoking. Whether it's ongoing inflammation or whatever it is, this is a disease that affects people. My patients with COPD don't like to be called COPDers. They're people who happen to have COPD. They often have multiple other problems. We need to motivate primary care and family practice to understand that they play a role here as well. And to be perfectly honest with you, I think that's one of the things we're going to need to do early on if we're really going to make a difference.
What can they do?
We have treatments now. Don't get me wrong, we need better, but we have treatments now. Most of my patients can live decent lives with this. Between exercise programs and taking the appropriate medicines, do we need better? Do we need more individualized? Do we need cures? All of those things. But we can make the lives of people better today, and that's what we need to do.
Part of the onus, though, it's also depicted in goal 2. That is, we need to increase knowledge for healthcare providers. And that's one of the major recommendations. Trying to make a trade union between the patients on one side and those that are providing care. So it needs to be a bi-directional dialogue that needs to be installed.
That's absolutely
and
correct.
all the organizations are going to work together to try to put together this knowledge base that can be distributed and available for them.
So do you think there needs to be more education of the primary care doctors on what signs and symptoms of COPD?
Yes, I think that there does, but I think that we need to bring the American College of Physicians and family practice organizations to this mix. We're not going to be successful without this. I mean, most COPD can be handled by people different than me. If they don't need transplants, if they don't need an interventional therapy, most COPD can be treated really quite well by people who care. The problem is making sure that they understand what's available and understand that this is about treating the person and not just treating the disease. And that's something we all need to do better.
I would add one thing. If you have a diagnosis of COPD, do a simple blood test to test for alpha-1.
Yeah, I would agree
to
with
make
that,
sure you're
too.
getting the right treatment.
We are going to run out of time, but the COPD National Action Plan is live. You can get it at COPD.NIH.GOV or at COPD Action Plan. Over there, you'll find also additional materials that will help to spread the news and help your organizations to participate in implementing the action plan. Thank you all.